Everyone, we'll get started in a moment. So thank you. We'll get started in about 1 or 2 minutes. Thank you so much.
Hold on, let me take a look.
So go to Zoom. Yeah, open it. Yeah. Click on it. Click on participants, and then click on invite. Copy invite links. This, and then just delete. Yes. Yeah.
All right, Dr. Williams? All right, you should see an email from me within 1 minute. Please tell me that. Okay, do you want
You
to
didn't get the part email.
refresh the email? Refresh your email? Do you know how to refresh your email?
Should I go out of the previous platform that I'm waiting on?
Yes.
Yeah, well, yes, you should. Go ahead and get off the previous platform. Now go back to your email, refresh it, and then you should see an email from me. Is there a link in that? Okay, can you turn on your camera?
There. Can you see me?
We see you and hear you, my dear.
Okay.
All right, we're back.
I'm going to turn the phone off.
Yeah, as long as somebody's doing that. Move his face up. Thank you. All right, good morning. Good morning. One more time, good morning. All right, thank you. When I teach in front of the class, I like people to respond so I know that we are awake and alive and ready to go. My name is Keisha Pollock Porter, and I have the great privilege and honor of being the chair of the Department of Health Policy and Management at the Bloomberg School of Public Health. I'm just thrilled to welcome you all today. I'm excited to be your master of ceremonies for the event, and my job is to keep us on time. I know we're starting a little bit late, but we'll catch up, so don't worry. Excited to welcome you all to the second in the series of the Hope Challenge, Health Opportunities for Policy Equity. And today we are focusing on the heart of the matter, and it is certainly intentional that it is the month of Valentine's Day. All right, so let's also celebrate that in a few weeks. We're going to start this morning's event with the welcome from the leaders of 2 of the 4 coordinating partners for today's event. First up, we'll hear from my colleague, my friend, my mentor, Dr. Daryl Gaskin, the William C. and Nancy F. Richardson Professor in the Department of Health Policy and Management at the Bloomberg School of Public Health. He's also director of the Hopkins Center for Health Disparity Solutions. Dr. Gaskin is a health economist who advances community, neighborhood, and market-level policies and programs that reduce health disparities. Dr. Gaskin will be followed by Mr. Marco Davis, the president and CEO of the Congressional Hispanic Caucus Institute, CHCI, a national nonprofit organization dedicated to developing the next generation of Latino leaders. CHCI provides leadership, public service, and policy experiences to outstanding Latino students and young professionals, and convenes members of Congress and other public officials, nonprofit advocates, and thought leaders to discuss issues facing the Hispanic community in the nation. He has more than 25 years of experience in a number of areas, including leadership development, advocacy, and civic engagement. Before joining CHCI, he was partner at New Profit, a national nonprofit venture philanthropy, and he also served in the Obama administration as deputy director of the White House Initiative on Educational Excellence for Hispanics. Let's give a warm round of applause for Dr. Gaskin and Marco Davis. Thank you.
Well, thank you, Keisha, for that kind introduction. And good morning, everyone, and welcome to a gathering that is about making a difference. The Health Opportunity Policy Equity Challenge Breakfast Forum. Today we're gathered to observe American Heart Health Month. Heart disease is a leading cause of death in the United States, and the heart health crisis disproportionately impacts women and minority populations. Heart disease is preventable if we manage modifiable risk factors. Preventing heart disease is not just about individuals changing their diet and exercising more, but there are also modifiable societal level risk factors that must be addressed if we are to achieve healthy heart equity. This gathering brings together internationally renowned experts in heart health to give us a call to action. So get ready to be inspired to do something that will promote heart health and change lives. At the heart of the Hope Challenge is a mission that is clear and compelling to create a brighter future, healthier and more equitable for all. The economic news indicates that the nation is on the road to prosperity. Wages and employment are up, inflation and unemployment are down. The stock market is booming, and corporate profits are up. However, if we're going to sustain this kind of prosperity, we need healthy people. Otherwise, poor health will lead to rising healthcare costs, declining labor productivity, which will erode our prosperity. We need to ensure that everyone enjoys good health by leveraging the power of public policy to eliminate those glaring racial and ethnic health inequities that shouldn't exist in our society. Now, let me be plain. We got a problem at our hands. Too many people suffer from preventable health conditions. This is not just a national crisis, it's a national economic crisis. It's literally dragging down our standard of living. Preventable health conditions are robbing us of precious years, dampening our productivity, and adding unnecessary and excessive healthcare costs to our society. Unfortunately, the brunt of these ills fall on our fellow citizens who identify as African American, Hispanic, Native American, Alaskan Natives, Asian Americans, Pacific Islanders, and the LGBTQIA plus communities. However, there is good news. We don't just have to lament these problems. We are here to talk about solutions. This is why the Johns Hopkins Center for Health Disparity Solutions, along with our partner, the Congressional Hispanic Caucus Institute, the Congressional Black Caucus, and NMAC, have convened us together today. And I want to thank the Johns Hopkins University Nexus Award Program and the William C. and Nancy F. Richardson Professorship for their generous support in helping us organize and convene the Hope Challenge Breakfast here at the Bloomberg Center. Our goal is to shine a spotlight on health policy and needed to address inequities in heart health. We have two exciting panels that will address inequities by implementing solutions in the clinic, in the environment, and among the social determinants of health. In addition, we have international experts. To our international experts, our second panel will be moderated by Peabody Award-winning journalist Mariana Atencino. Hope Challenge is about promoting health equity. Health equity is about giving everyone the opportunity to achieve the American dream. I'm reminded of the poem, and I quote it often, that says, from Langston Hughes, that says, I too sing America. I'm the darker brother. They send me to eat in the kitchen when the company comes, but I laugh and eat well and grow strong. Tomorrow I'll be at the table when company comes, and no one will dare say to me, eat in the kitchen. Then besides, they'll see how beautiful I am and be ashamed. I too am America. Health equity recognizes that all of us have a right to sit at the American table and enjoy life, liberty, and the pursuit of happiness. Health equity insists that our society implements policies and programs in such a way that everyone has a lower risk of developing heart disease, and if some do, they have access to life-saving medical care so that they can recover and live long and productive lives. Asking our decision makers to incorporate health equity in their policies and programs is merely asking them to practice the golden rule. Do unto others as you would have them do unto you. In other words, treat no one as though they are less than you or those in your community. And even if you perceive someone as the other, make sure your policies and programs are as effective for them as they are for you. The golden rule standard in our policies and programs should insist that our policies and programs should be effective for all of us. So welcome your brother and your sisters to the American table, because they too sing America. So don't just sit back, getting ready to be engaged, share your brilliance. Help us pave a way towards a society where everyone, regardless of their background, gets a shot at a healthy and prosperous life. Thank you for being here for on this Heart Health Month. Together, let us turn the tides on disparity and make health equity a reality. And now I'm pleased to turn this over to our event partner, Marco Davis, the President and CEO of the Congressional Hispanic Caucus Institute, to bring welcome remarks. Thank you.
Thank you, Dr. Gaskin. Buenos días a todos. Good morning, everyone. Very happy to be here, and I want to make sure to thank all the folks who were instrumental in making this day possible. First and foremost, of course, Johns Hopkins University, in particular, the Johns Hopkins Center for Health Disparities Solutions and its able leadership. I also want to thank our partners, the Congressional Black Caucus Foundation and the National Minority AIDS Council, or NMAC. I also want to thank the dedicated staff here at the center, as well as at our partner organizations, as well as all the folks organizing today's event. And I want to give a special shout out and appreciation for Dr. Maya Rocky Moore Cummings, the genius driving this entire effort. Now, this Hope Challenge, as Dr. Gaskin very ably described, is an effort to raise awareness about the health disparities that exist, about the issues that address us. In this particular case, today we're gathering to talk about issues around heart health, hypertension, cardiovascular disease, and stroke. And it's part of a larger effort, as I mentioned, to not just raise awareness about these health disparities, but to point to policy solutions. The idea is if we can both shine a light on the disparities as well as point to the solutions that are needed, it can help encourage, inspire, dare I say, motivate our policymakers, our public officials, our community advocates, and even the private sector to take action, to address these disparities, to make sure that everyone has access to quality health care, to make sure that the differences in the prevalence of these diseases and the disparate impacts that these diseases have on particularly underrepresented communities, in this case Latino and African American communities, that those disparities can be eliminated and that everyone has a much better life and well-being, which actually benefits our society overall. And so that's a key purpose of this challenge and why we're so excited to partner with all of our colleagues and to be here and to have this discussion today. And there's another purpose that CHCI has, which an event like this helps to further, and that I think our partner organizations do as well. You see, as was mentioned earlier, CHCI's mission is to develop the next generation of Latino leaders. For us, that's a very critical need, because you may not know it. Unfortunately, it's not as well known as it should be. But the Latino community in the United States is nearly 20% of the American population, almost 1 in 5 people. And yet, when it comes to public office, when it comes to elected officials, we occupy less than 2% of the elected official positions. That means that even though 1 out of every 5 Americans is of Hispanic descent, less than 2 out of every 100 elected officials come from those communities, which means that when people are making decisions about public policy, when people are deciding new laws that affect everyone in the country, when people are deciding where to distribute resources, when people are deciding what types of research to require, overwhelmingly, folks from this large segment of the United States population are not in the room, are not able to make decisions. They are not, as Dr. Gaskin so eloquently quoted from Langston Hughes, they are not at the table. And we feel that that's a critical problem. We feel that that's one of the issues that hinder us from addressing issues like these disparities, because there isn't someone in the room saying, hey, there's a problem here, or hey, maybe there's a different way to approach this challenge to ensure that the most underrepresented are better served. And so that's another outcome and benefit of an event like this, which is to shine a light on these issues, to bring forward these solutions, but also to share those with our own communities so that leaders in the Latino and the African American community can both be inspired to take action themselves, to call for better equity in health policy, but also can be inspired to take their own seats at the table, to take matters into their own hands, these matters of the heart, and to address those issues by being in the place where the decisions are made so that we can ensure better health outcomes, not just for our own communities, but truly for everyone, which will make us a stronger nation, which will make us a better economy, and will make us more globally competitive. And so we're very, very excited to be here today. We think it's going to be a fabulous conversation. We think there's going to be a lot to learn, so we hope you will have your pencils sharpened, your phones and computers well charged, so that you can take away the statistics that you're going to hear, so that you can take away the important information, then you can, and the messages that you hear, and the policy solutions that will be discussed here on the stage, so that you can share those with your peers and your colleagues. You can reach out to your own leaders, whether it be community advocates, whether it be corporate leaders who support the work, whether in healthcare or not, and most importantly, to policymakers, so that you can raise your voices and highlight the need that we have to address these disparities. So once again, welcome. Thank you for taking the time to join us this morning, to be here with us, and we look forward to a really, really exciting discussion. Thank you very much.
Thank you so much, Daryl and Marco. I'm excited for the day ahead, and I'm thrilled to welcome our first panelist. So our first panel for today is called Life Support, a biomedical approach to closing disparities in hypertension, cardiovascular disease, and stroke. Can the panelists please come to the stage and take their seats? And while they're doing that, I'm going to introduce the panel's moderator, Dr. Maya Rockeymoore-Cummings, who is a visiting scholar and my colleague at the Johns Hopkins Bloomberg School of Public Health in the Department of Health Policy and Management. Dr. Rockeymoore-Cummings is a widely known commentator, activist, and strategist. She's also founder, president, and CEO of Global Policy Solutions, a social change strategy firm that seeks to drive society towards inclusion. Maya, thank you so much.
Thank you, Dr. Pollack-Porter, and good morning, everyone. I am so pleased that we're all here today, gathered for this very important issue. I will let the remarks that have been already given stand as an introduction for this panel. Today, we have the unique privilege of learning from and engaging in dialogue with giants in the field of medicine. Now look at how modest these gentlemen look. All of them, the gentlemen on the screen, the gentlemen sitting here, they are, listen, I'm not gonna do justice to their bios, their full bios today. But when I tell you that we are certainly in the company of giants, I want you to know that I absolutely mean it. Physicians they are, who have dedicated their careers to understanding and identifying solutions to some of the most complex and difficult health issues of our time. These world-class experts are pioneers in the areas of research, treatment, education, and advocacy. I am honored to introduce them in the order of their presentations. Once their remarks have been delivered, we will engage in a brief dialogue. Then I will open it up to you, the audience, for questions so we can have a whole full dialogue. And then we will, of course, move on to the next panel session. But I should state up front that our first panelist, Dr. Richard Allen Williams, planned to attend in person until the atmospheric river hit Los Angeles. And he currently has water lapping at the front door of his front steps. And so he could not leave Los Angeles to come here today. And so we made accommodations for him to join us via Zoom. Dr. Richard Allen Williams is an international expert on hypertension, healthcare disparities, dyslipidemia, diabetes, obesity, heart failure, and sudden cardiac death. He is the founder and president of the Minority Health Institute, the 117th president of the National Medical Association, and the founder of the Association of Black Cardiologists, also known as ABC. A cum laude honors graduate of Harvard University, whose medical school also gave him its Lifetime Achievement Award. Dr. Williams attended the State University of New York Downstate Medical Center, where he received his medical degree. He completed a cardiology fellowship at Brigham and Women's Hospital and Harvard's Medical School. Among other roles, he has served as chief of the Heart Station and head of the cardiology department at the West Los Angeles VA Medical Center, and as clinical professor of medicine at the UCLA School of Medicine. And I should add, he was the first African American to ever achieve full professorship there. The author of 8 books and numerous chapters and papers, Dr. Williams has received the American Heart Association's prestigious Lifesaver Award and the Scroll of Merit and Distinguished Leadership Award from the National Medical Association, their highest honor. Indeed, this is Black history here via Zoom today. So thank you, Dr. Richard Allen Williams. But before we actually have you, I'm going to introduce the others so I can take a seat, and then they can come up after Dr. Williams. After he speaks, Dr. Carlos Rodriguez will speak. And he is a board-certified clinical cardiologist who serves as a professor of medicine, epidemiology, and population health, vice chair of academic affairs for cardiology, director of cardiovascular research, and director of cardiovascular epidemiology at the Albert Einstein College of Medicine. You do that all at once? Is that possible? Okay. He was born in the Dominican Republic and raised in Washington Heights, Manhattan. He is a graduate of the University of Massachusetts at Amherst and subsequently earned both his MD and MPH degrees concurrently from Columbia University College of Physicians and Surgeons and School of Public Health. He then completed a 3-year internal medicine residency and a 4-year fellowship in cardiovascular diseases and advanced echocardiography at Columbia University's Medical Center. A prolific researcher, Dr. Rodriguez has published over 260 peer-reviewed manuscripts, book chapters, and abstracts. I think that I read that one of his NIH applications received a perfect score, which is like unheard of. Dr. Rodriguez has been the recipient of the American Heart Association Clinically Applied Research Grant, the Association of Black Cardiologists Hawthorne Searle Young Investigator Award, and a Career Development Award funded by the National Heart, Lung, and Blood Institute. And last, but certainly not least, is Dr. Chiadi Ndumale. He is the Director of Obesity and Cardiometabolic Research, Director of the Heart Failure Prevention Program, and Associate Professor of Medicine and Epidemiology in the Division of Cardiology at Johns Hopkins University. Dr. Ndumale is a preventative cardiologist with doctorate-level training in epidemiology who leads a research program related to characterizing the relationship of obesity and cardiometabolic risk factors with the development of cardiovascular disease with a particular focus on heart failure risk and to refining strategies for cardiovascular disease prevention. His work additionally addresses the impact of social determinants of health on cardiometabolic risk factors and downstream cardiovascular outcomes. And he is a core faculty member in the Johns Hopkins Center for Health Equity. Dr. Ndumale received his MD from Harvard University and his internal medicine training at Brigham and Women's Hospital, where he also served as chief medical resident. He subsequently trained in cardiology at Johns Hopkins University, where he was also chief cardiology fellow in his final year, and where he also received his MHS and PhD in epidemiology. Can you please join me in welcoming these esteemed and highly distinguished experts? And so with that, we are going to have an assisted conversation with, or a presentation from Dr. Richard Allen Williams first.
Good morning. Am I on? I hope you can hear me. Okay, this is Dr. Richard Allen Williams, and I'm happy to be here, at least virtually. I wasn't able to make it, as Maya indicated, to be there in person because of the weather situations here in Los Angeles. Couldn't get out. In any event, I'm going to give a brief presentation this morning. Happy to be invited to this awesome program. My topic is going to be healthcare disparities in cardiovascular disease, and I'm going to focus on Black women in particular. But before I get started, I wanted to mention something that you are all aware of, and that is that this is not only Heart Health Month, but also Black History and Heritage Month. And so it's not unexpected that I would be focusing on the problems of heart disease in African Americans or Blacks. I wanted also to mention that we need to take seriously what Dr. Gaskin mentioned in regards to trying to move into the policy area regarding these healthcare disparities in cardiovascular disease. And to that point, last week I was able to meet with several members of Congress, in particular, Congresswoman Maxine Waters and Congresswoman Lisa Blunt Rochester regarding healthcare disparities and health equity issues for all the entire minority population in the United States. I had planned to meet with another couple of congresswomen, members of the Congressional Black Caucus this week, but wasn't obviously able to come to Washington. In regards to policy and so forth, to make a case in point, I wanted to mention that Congresswoman Lisa Blunt Rochester has a bill pending in Congress which she wants you to be aware of, which is in the cardiovascular space. It's what we call the blood clot bill. And I won't go into details as to how that came about, but it's something that needs your support in regards to trying to overcome many of the disparities in cardiovascular disease for Black and brown people. With that, I'm going to launch into a quick presentation of some clinical aspects of cardiovascular disease and go through several slides very quickly, starting with this slide that has to do with the CV disease statistics in African American. I'm not going to try to read all of this, but indicate to you the salient points that African Americans are about 2.5 times as likely as the general population in the US to die from complications of high blood pressure or hypertension. And approximately a third of African American adults have high blood pressure, and that's among the world's highest rates. The prevalence of myocardial infarction, another cardiovascular disease, in African American women is 3.3% compared to 2% in white women. African Americans have 1.3 and 1.8-fold increased risk of suffering a non-fatal or fatal stroke when we come to consider that, respectively, compared with whites. And African Americans are about twice as likely as Americans in general to die from diabetes, which is considered a cardiovascular disease, since most of the people who have diabetes die from cardiovascular disease or its complications. Diabetes is the third leading cause of death in African American women. So let's have the next slide. And I'm going to very briefly go through some of those things that I presented on the statistical front. Hypertension is found in 34% of Blacks, 28 as opposed to 28% of whites. It has an earlier onset in Blacks, and several complications, including heart attack, stroke, kidney failure, occur earlier in Blacks, and there's greater resistance to treatment of hypertension in Black patients. Next slide. Here you see some of the complications that can occur from high blood pressure, including stroke, blood vessel damage, including arteriosclerosis or hardening of the arteries, heart attack, heart failure, kidney failure, and even diseases of the eyes. So high blood pressure is responsible for a number of complications which many people in the minority community suffer. Next, please. Stroke is the next one that we will consider as far as clinical features are concerned. There are 500,000 strokes per year and 150,000 deaths, which makes it huge. And it is the only cardiovascular disease which is seeing an upsurge on a perennial basis, as opposed to things such as acute coronary syndrome and so forth. It's the third leading cause of death after myocardial infarction and cancer, and hypertension is the major risk factor in blacks. Blacks die twice as frequently as whites, and prevention is possible. Now, I mentioned that hypertension is the major risk factor for stroke in blacks. In whites, we see strokes occurring more commonly from arteriosclerosis as opposed to hypertension. And so I often say that there are different strokes for different folks. And that is actually true. And so we need to keep in mind that control of hypertension will help us control the occurrence of stroke. In heart failure, next slide. In myocardial infarction, which is heart attack, basically, it's the greatest killer of mankind, as Dr. Gaskin indicated, with 1.5 million deaths per year. The death rates are higher in blacks, and this is something that we've only learned in the last half century, because it was thought previously that black people did not suffer from heart attacks. The death rate is higher in blacks, and black women in particular are at the greatest risk. Death rate is 35% higher than in white women. Next slide. Now I'm going to finally introduce many people to a relatively new disease which needs to be considered and is very serious consideration, which is especially prominent in the black population. We call it ATTR-CM, or amyloidosis transthyretin cardiomyopathy. It's a, quotes, new heart disease in blacks, and it's caused by a hereditary transmission of a genetic mutation. The phenotypic expression is amyloid cardiomyopathy. I can't go into details about that during this brief presentation, but in any event, amyloid, a very sticky substance, is deposited in the heart muscle, causing it to dysfunction. 99% of the hereditary form of this disease, of those cases, are found in blacks, which is astounding. That means that 4% of the African-American population is unknowingly affected, with approximately 1.5 million blacks in the population being affected and not knowing about it. So this is a serious problem where we need to raise awareness. This is an incurable disease at the present time. Prolongation of survival is possible with early select treatment. Early diagnosis is really the key, and expert cardiology consultation is essential. There is availability of genetic testing and something called technetium-99m pyrophosphate imaging, which is an imaging test, and heart biopsy may be used in determining the diagnosis. Very principally, the black population must be made aware of this threat to our lives and well-being. And I've emphasized that, given that particular emphasis. Now, I want to end by saying something about heart disease that occurs secondary to COVID, because obviously that's within our realm of consideration and concern at this particular time. You must know that there are certain types of diseases or disorders of the heart that do occur in COVID, and it's estimated that approximately 80% of the people who are affected by COVID might have some type of heart ailment, whether determined or not. And that leads to a great deal of consideration and concern about what we need to do in regards to preventing COVID by making certain that people get vaccinated to prevent it. I'm going to end there, and thank you very much for the opportunity to present this information, and hopefully I can answer some questions that might arise. Thank you.
Excellent. All right. Well, it's a pleasure to be here at this really fantastic event with such illustrious colleagues. I am going to follow Dr. Richard Allen Williams' same train of thought, but I'm focusing more on hypertension, high blood pressure. And some of the things I'm going to say are Dr. Richard Allen Williams has already touched on. So I'll start with this slide, stating that half of the U.S. population has hypertension. So it's one of the most prevalent cardiovascular risk factors. There's a higher prevalence of hypertension in blacks, as you've heard already. And compared to non-Hispanic whites, non-Hispanic blacks develop hypertension earlier with higher average blood pressures and have a higher rate of the after effects, the complications of hypertension, with more cardiovascular mortality, more non-fatal and fatal stroke, and more heart failure and more end-stage kidney disease than non-Hispanic whites. There are also disparities in treatment and control of blood pressure. So only about 1 in 2 adults in the United States have their blood pressure controlled. And that's using the old thresholds of 140/90. When you use the new thresholds from the latest AHA guidelines, AHA-ACC guidelines, the rates of blood pressure control go even lower. Only 1 in 4 adults have their blood pressure controlled. So you have non-Hispanic blacks more likely to be treated, but less likely to be controlled compared to non-Hispanic whites. And less than half of Hispanics and Asians with hypertension are actually treated. And among those treated, you have only 1 in 5, less than 1 in 5, less than 20% of Hispanics and Asians have their blood pressure controlled. And as Dr. Richard Allen Williams already alluded to, hypertension is one of the cardiovascular risk factors that has some of the most profound effects on the cardiovascular system. You can see here how hypertension, arterial hypertension, causes a hemodynamic stress that leads to structural changes in the heart and vascular system. You have left ventricular hypertrophy. That you see the heart muscle on the left side get bigger, and it becomes fibrosed and functions less efficiently. You have increased dilatation of the left atrium, the top left chamber of the heart. You have dilatation of the aorta, and you have remodeling of the heart. And eventually, that leads to functional changes where the heart develops diastolic dysfunction and becomes stiff and can't relax, and then systolic dysfunction where it cannot pump efficiently, leading to heart failure. And with the dilatation of the left atrium, you have left atrial dysfunction and atrial fibrillation. all this, as well as atherosclerosis, stroke, and kidney failure, all come from hypertension, leading to the list on the right of heart failure, aneurysms of the aorta, atrial fibrillation, coronary artery disease, stroke, and chronic kidney disease. So along with that, knowing that hypertension precedes the development of heart failure in over 90% of cases, you see that similar to what Dr. Richard Allen Williams pointed out with stroke, we see the same thing in heart failure, where hypertension seems to be the leading cause of heart failure among non-Hispanic blacks, whereas in non-Hispanic whites, atherosclerotic disease or ischemic heart disease seems to be a more prominent cause of heart failure. So hypertension is more of a factor with regards to causing heart failure among non-Hispanic blacks and non-Hispanic whites. So with all this said, there's a concept of population attributable risk. We are public health. Most of us are public health persons after all. So, we've heard this concept before where population attributable risk allows us to estimate the proportional public health impact if a risk factor were eliminated. So if hypertension was eliminated, what would be the impact? And actually, hypertension has one of the highest population attributable risk of any cardiovascular disease risk factor, where it's estimated that optimal blood pressure control or eliminating hypertension could prevent 1/3 of cardiovascular events in men and half of cardiovascular events in women. And how do you eliminate hypertension? Well, we know the concepts of primary prevention. That would be one thing. If you could eliminate it before it starts, so if you can prevent the disease from developing, that's one way. And that's focusing on risk factors such as diet, obesity, physical inactivity, and socioeconomic factors, all of which you'll hear more throughout today. But then the other way of eliminating hypertension is through secondary prevention. Secondary prevention focuses on minimizing the consequences of a disease. So that focuses on hypertension control. Again, also focusing on risk factors, but primarily on treatment. And again, that highlights the important disparity and travesty that only 1 in 2 adults in the United States, about 50% of adults with hypertension, actually have their blood pressure controlled. So I wanted to bring to your attention the SPRINT trial, which was a trial with the National Institutes of Health, a landmark trial. I was fortunate to be an investigator in SPRINT and one of the leaders in SPRINT. And SPRINT was really landmark. It was the first trial trying to treat to a goal systolic blood pressure less than 120 millimeters of mercury. And it was doing this in a population of hypertensives who were at risk for cardiovascular disease. And you can see that the trial was successful and the Kaplan-Meier curves show that indeed treating to an intensive blood pressure was successful. Lower blood pressure is better. There was a 25% reduction in cardiovascular disease events and 27% reduction in all-cause mortality by treating to a lower blood pressure. But what I found most interesting and most satisfying about being a part of SPRINT is that SPRINT enrolled over 40% underrepresented racial and ethnic groups. Non-Hispanic blacks, 30%, Hispanics, 11%. And it's really one of the only and first hypertension trials to do this. And it showed that blood pressure control, intensive blood pressure control, can be achieved among blacks and Hispanics, and that blacks and Hispanics derive the same benefits as their counterparts from blood pressure control. And I'm not going to walk you through this algorithm, but in SPRINT, there was a blood pressure management strategy that was utilized, as shown here. And this blood pressure management algorithm, I think, can, and Sprint investigators also think, can inform clinical practice and help replicate the benefits that we saw in this trial. This approach was safe and effective. It did require monthly clinic visits for blood pressure checks, and about 2 to 3 medications, blood pressure medications, were utilized at maximally tolerated doses. Oversight was provided to make sure that blood pressure levels were achieved at each clinical site. And the beauty of this algorithm is that it addressed therapeutic inertia, and that is some of the resistance that physicians may have to increase blood pressure medications up to goal. So with that in mind, there are many factors that lead to the hypertension health disparities that I've mentioned, Dr. Richard Allen Williams mentioned as well. It's multifactorial, the causes. And the first domain where these disparities stem from is the healthcare system. The lack of health insurance among underrepresented racial and ethnic groups, medication access. There's disparities in medication access. The reimbursement in RVU structure, which overburdens providers from actually being able to focus on things like treating blood pressure. Provider-related factors such as implicit bias, therapeutic inertia, which I mentioned, patient-level factors of reduced health literacy, distrust, medication adherence, and then there's the environmental factors, which we've, and the social determinants of health, which we've come to know under the umbrella of structural racism, of wealth, income, education, occupation, unemployment, food deserts, transportation, and neighborhood decay and safety, are all important in driving hypertension health disparities, because even when resources are available for hypertension treatment, greater social deprivation still significantly contributes to poor hypertension control. So what are some of the solutions? This list is not inclusive, but I did want to highlight some things. We can continue to focus on improved access to care. We've lost some ground in this domain, and we need to keep our eye and our focus on improving access to care. Achieving pharmacoequity. I mentioned how medication access is not equal across all racial and ethnic groups, and that really prevents providers from achieving blood pressure control. Implementing blood pressure protocols. I believe that these protocols should be implemented across institutions. Every institution should have one, and there should be oversight on these protocols to make sure that goals are achieved. And with regards to goals, we need to focus more on hypertension by setting national and institutional hypertension control goals, where as a nation, we aim to achieve over 80% of hypertension control rates rather than the 50% that we are now. And again, this is particularly important given that hypertension so predominantly affects all populations, but more so Black and Hispanic populations. We need to reward achievement for achieving hypertension control and provide the resources to do so. One of the resources, or a couple of the resources that I want to point out, are community health workers. Community health workers, it has been shown in multiple studies, multiple research protocols, that when you have community health workers helping to lead coaching interventions, they are effective in achieving blood pressure control. Community health workers provide a connection to the community. They provide health education to the patients, and they advocate for the patient's social determinants of health needs. And it's been shown that having community health workers increases medication adherence and compliance to doctor's visits. But unfortunately, there's no federal regulation, there's no federal law that facilitates uniformly across the country the use of community health workers in achieving blood pressure control. And the last factor that I'll highlight is establishing hypertension centers, which I think are key to establish at every institution to allow a place for providers to refer hypertension patients to ultimately achieve control. Thank you.
It's an honor to be here with all of you and to be here with esteemed colleagues. And I'll try to build on the remarks by Dr. Alan Williams and Dr. Rodriguez in this brief chat described as hypertension disparities as a key component of a larger clinical and public health challenge. Everybody has described the fact that we have significant and important trends to highlight in terms of cardiovascular disease mortality. There are two on this graph that are worth pointing out. So first of all, over the last maybe 5 decades, we've had continuous drops in cardiovascular disease mortality, stopping smoking, recognizing the importance of cholesterol, other kind of risk factor control. But there are two things that are very notable. So first of all, you can see that in the last decade, there's been a plateau in cardiovascular disease mortality for basically everybody. Things have just stagnated. And in some areas, like stroke, as was described, things are actually going in the opposite direction. Secondly, there's been a persistent and stubborn disparity with regards to cardiovascular disease mortality, with the most notable pattern being the higher cardiovascular disease mortality in non-Hispanic blacks relative to other race and ethnic groups. Now, one part of this problem, as has been described, is hypertension. And I'll briefly just say what everybody else has said: 122 million adults, responsible for 691,000 deaths in 2021, many people undiagnosed, not even aware of having high blood pressure. As Dr. Rodriguez stated, 3 in 4 adults uncontrolled with regards to their high blood pressure. Among them, 34 million who are untreated, so either not prescribed medications or not taking them as prescribed, and then another 33 million who are undertreated. And the result of all of this, by the way, it's important to note that the blood pressure differences are stark and persistent by race and ethnic groups. So this is showing data over the last 20 years, and you can see that non-Hispanic blacks have higher blood pressure than non-Hispanic whites back in 1999. This difference has not changed in any way over the last 20 years, and that's seen among individuals who are taking antihypertensive medications and among people who are not taking antihypertensive medications. And the studies demonstrate, as has been described, that most of this difference is really related to social determinants of health at multiple levels. What can we access? What are the resources individuals have? What's the environment? What is the psychosocial stress? Various levels of social determinants of health that are contributing to these differences. But it's also important to recognize that hypertension is one aspect of this problem, and it doesn't happen in isolation. So if you look at disparities here, you can see hypertension is in this first graph here, the green bar being non-Hispanic blacks, and you see, of course, they have the highest rate of high blood pressure, as has been described. But we also see higher rates of obesity among non-Hispanic blacks as well as Hispanics relative to white adults and Asian adults. We also see significant disparities in diabetes, with highest rates among non-Hispanic blacks as well as Hispanic adults. And we actually see very similar trends for our youth as well, and not really as many differences with regards to high cholesterol. So these hypertension, diabetes, obesity, this is not a coincidence, because these factors are all linked in what we call cardiometabolic risk factors. This really has led to a reconceptualization of how we think about these factors in some new work by the American Heart Association. The reasons for this are, number one, that most hypertension is actually downstream, related to overweight and obesity, but it doesn't just happen in isolation, It's also linked to other conditions like diabetes and to chronic kidney disease. As a result of this, there's this newly described construct of cardiovascular kidney metabolic health that reflects the fact that we see these close relationships. And there's a staging construct because really we can think about just treating what we see in front of us in terms of hypertension isolation, but more effective will be to start thinking about how we prevent this, how we think about the life course of this, and also think about the other factors associated. So you can see here, we start in stage 0, where there's a state of ideal cardiovascular health, where there's none of these factors happening at all, but stage 1 is the beginning of this adiposity, excess adiposity, overweight, obesity, that actually most of the time leads to the development of hypertension, but also other factors associated with that, abnormal cholesterol values, diabetes, and kidney disease. And that sets the stage for preclinical, asymptomatic heart disease, and then finally clinical heart disease. And when that happens, that's where our mortality begins. So we want to think about this staging in adults and youth to promote prevention. Another really important point is that this does not occur just on its own. This is occurring in a broader social context, this socio-ecological framework. We need to be thinking about these factors as a result of societal factors, community factors, interpersonal factors, all of these affecting various aspects of what people can do in terms of healthy lifestyle, and then also how people can work with and access the health system. So the cardiovascular kidney metabolic health construct emphasizes thinking about social determinants of health, screening for those, and then continuing to think about them and how we predict risk. As Carlos has described, Dr. Rodriguez has described, also talking about this in terms of our clinical approach, using community health workers to actually be not just screening for, but also addressing social determinants of health and having them as part of the care team. So this social context being very important. And then one final update I want to highlight is that there's an updated approach to cardiovascular risk prediction by the American Heart Association that reflects various trends that we've been talking about. First of all, there's not just an emphasis on heart attacks only, but thinking about these other conditions, heart failure, stroke, and predicting total cardiovascular disease to take the full picture for everybody. We're seeing these things happening earlier and earlier, so it's predicting risk at age 30, which is 10 years earlier than we've been usually predicting this because of this earlier prediction. And then we not want to just predict 10-year risk, but also long-term 30-year risk to understand risk, particularly in younger adults who may not have an immediate risk for heart attack, but long risk for disability. Hypertension, as well as these other factors, are included in here, but I also want to really highlight that social determinants of health are starting to be incorporated into prediction by using social deprivation index as a place-based measure of social determinants of health. And really, the overarching goal is that we think about hypertension and hypertension disparities, but not just in isolation, that we're thinking about the whole person. When we see people in clinic, they're not just coming in with hypertension. They're coming with hypertension and diabetes and chronic kidney disease, but they're also coming in as a person with a broader social context, a person who can't afford medications or can't, who has difficulty with transportation to the clinic or can't, who has interpersonal and other kind of concerns, psychosocial stress. So we want to think about the whole person, their conditions, but also their social context, and to really support a holistic and coordinated approach to reducing disparities in the overall population. So thank you very much, and I'll stop for questions too.
Thank you very much. Sharon, is that you? So, you know, when you publicize on your social network, you expect to see your friends in the audience. But I heard you ask a question, so I'm going to ask you to actually hand her a microphone. I'm going to go ahead and talk, and then we'll get to you as soon as we open. And if other people have questions, I invite you to, raise your hands when you're ready, and they will come to you to hand you the microphone as well. So, Dr. Ndumale, I've got to start with you. That was a fascinating graph. You're basically saying, or the science is saying, that your heart condition is not separate from your kidney condition, which is not separate from your metabolic condition, which is your obesity or your adiposity or et cetera. So my question for you is that in that chart that talked about the social determinants, at the very bottom, was the whole notion of genetics and epigenetics. what percentage of this whole CMK or CKM phenomena is related to that, and what percentage do we know is related to everything else?
Yeah, it's a good, it's a good question. So I would say overall, we see a good amount for some of these conditions of what we call heritability. So we see things happening from one individual and to the next people in the same generation, the same household. However, when we go to the genetics, actually, for a lot of what we're talking about, not a very can currently be explained by genetic mutations by themselves. Most of what we're looking at is going to be explained by shared environments, shared social challenges and needs, and a broader kind of a social context that's contributing to why we see this. The genetics are important. So it is the case that if you have somebody who has more of a predisposition to developing obesity, to developing hypertension, to developing diabetes, in the wrong social context, that's way exacerbated. So we see that even farther and more challenging in that population. There are some conditions, though, where there is a very important genetic difference. So Dr. Alan Williams brought up ATTR cardiomyopathy. That is a very important biological challenge that has some genetic underpinnings that are different by race, ethnic groups. We see there's a newer cholesterol measure called lipoprotein A that I suspect next year will be on everybody's lips because there's going to be some new clinical trials that will come out about this. And that is dramatically different by race. So we see much, much higher levels among our African American patients and some other groups like Indian Americans than other populations. There are some pieces that are genetic. And when you do have genetic predisposition, it makes it worse. But most of what we're seeing is happening from a social context. And it highlights what Dr. Rodriguez said. We know that if you put the right resources in place and you talk about the social determinants and you get community health workers and you actually think about how you could holistically support patients, you can get that blood pressure controlled. So we know that if we do the right things and provide the right support, we can start to address these disparities.
So I want to dig in because I think that we toss around terms and we're not quite familiar with them all. But you said heritability.
Yes.
Could that also be equated with adverse childhood experiences?
Yes, so that is certainly part of what, so heritability is just something that's being passed on from generation to generation, but it doesn't all necessarily imply that it's genetic in terms of your DNA. And yes, experiences from early life. So we know a lot of what we are seeing, and that's why this CKM concept is for youth and for adults. Much of it starts early in life, and certainly it's traumatic experiences, certainly it's the social context and what you have access to, and certainly it's also some of those early risk factors that when they begin, they don't get better over time, particularly when unaddressed. We actually see them tracking and worsening over time. So those are the things.
Well, so then I've got to ask this question. Are Black and brown populations, are they ever at stage 0? In that CKM model?
Yes, they are.
So stage 0 is birth?
No, so stage zero, no, but it's a very important point. It's a very important point. So stage 0, most of the time, we see that in early life. So most of the time it's among youth. It can be among younger adults. It is going to be that, what we see is that over time, people will start transitioning over those stages. That transition happening earlier for Black and brown youth. So we are seeing that difference. And we do need to actually, because this is not, there's not a fault in this. This is a situation where the challenge is the broader social environment. So it's a question of the things that have been most helpful with supporting better stage 0 or ideal cardiovascular health have been better school-based programs, have been better family support, have been better kind of a really wraparound support for making sure people have the same opportunities to have a healthy lifestyle, and also addressing the real stressors that are different among different groups. So you're absolutely right that there is a difference, but it's the goal that we need to be targeting, and we need to not say this is individuals' faults. This is a societal challenge, and we need to be figuring out ways to support this better from a societal standpoint.
So that actually is a good segue to Dr. Rodriguez. because you mentioned in your discussion about hypertension a term called implicit bias. You also, I think, mentioned structural racism, along with that stigma and discrimination. So can you talk about, because, you know, if theoretically at birth we're all at stage 0, you know, and that yet we see these differentials according to race and ethnicity, then there's a difference that happens that might be more intense, right, for Black and brown populations. And so can you describe how the effect of stigma and racism could possibly impact the body in this way?
Yes, well, I think Dr. Ndimile really summarized everything very, very, very well. We do start as stage 0, but as minority populations, as Black and brown people, we transition much earlier because of the societal factors and societal impact and the stress and the lack of resources and the challenges that we face. Discrimination and stigma is just one of them. And many times that's internalized, where it can affect homeostasis, our own body's ability to maintain balance. And it can manifest itself in hard to control blood pressure and lead to more left ventricular hypertrophy and enlarged hearts, which we see more left ventricular hypertrophy in Black and Hispanic populations than in non-Hispanic white populations. So the structural racism, I think, is there to perpetuate many of the social determinants of health that I listed out and that others have highlighted. And it's a societal issue. I mean, I can't stress enough how good Dr. Ndimile really summarized everything. It's a societal issue. It starts early, and but it leads to a point that I always like to say when it comes to your earlier question about genes, is that genetics may load the gun, but the environment pulls the trigger. Family history is still one of the strongest risk factors for hypertension or diabetes. But having that family history doesn't mean that you need to succumb to that, because the environment has a lot to do with pulling the trigger to make that family history manifest. So recognizing that the environment has a lot to do with it, the challenges, the discrimination, the social determinants of health, and other things that can impact us and Black and Hispanic populations, and addressing those can help us fight against the family history that some of us may carry. And I think you mentioned one other thing, which was about implicit bias. So the reason that was on my slide and in my talk about hypertension control is because many times it really has to do with, I listed it as a provider factor that perpetuates hypertension control disparities. Because many times a provider may be looking at a minority patient, a Black or Hispanic or Asian patient, and have already an idea whether or not this person can achieve blood pressure control, whether or not this person can achieve actual optimization of their risk factors. And that type of bias can be unconscious many times. And unless we are aware of that bias and we work against or through that bias with our patients, we won't be able to treat them optimally. We have to recognize that.
How might AI and technology help with that?
Wow. That's that is a $1 million question.
Well,
I'd like to
I mean,
hear,
yeah.
I'd like to hear what others think, but I mean, my perspective is we're very early with AI. I think that it's beautiful technology with a lot of promise, but how it will impact health disparities, I think it's left to be.
Well, so the reason I
determined.
asked is because you mentioned that half of hypertension cases are uncontrolled. And that, implicit bias might be a part of this because physicians are not necessarily, they have preperceptions about whether people can, and so they're withholding treatment, essentially. Is that what you're saying?
No, I mean, implicit bias is unconscious by definition and by nature, but it does lead to a concept that I mentioned, which is therapeutic inertia, which is where, as providers may be less apt to intensify treatment to goals, evidence-based goals. And sometimes that is due not just to implicit bias, but to many other factors, be it, as I mentioned, the lack of time in seeing a patient, or maybe there's distrust in the physician-provider relationship that doesn't allow for that to fully happen. So there are many factors that go into therapeutic inertia, and implicit bias is just one of them.
So if a patient walks in and they're presenting with certain symptoms, and the physician is impaired by his or her implicit bias, if you're plugging the symptoms into an AI program, then it's raising these red flags about what this possibly could be. And if there are, like you suggested in your recommendations, if there are guidelines for what the protocol, for what should happen in every situation and case, then you've got technology then sending up the flag and saying that you have to provide this prescription and treatment. Is that not possible?
Yeah, you should be a researcher, and
Yeah, well, I
you should get
Well, shouldn't I?
you should get the perfect score on a grant.
All right.
But that's why I highlighted the blood pressure control algorithm, because having that algorithm helps to take away some bias and therapeutic inertia.
Dr. Richard Allen Williams, I'm coming to you in a second, but first we're going to go to Dr. Ndumale.
I'll be very brief. I just want to say that there's AI has some potential promise. The idea of algorithms, as has been described, and kind of making it less subjective for some ways can be helpful. However, one of the things that's a clear pitfall is it's all about whose data is being entered to describe what's standard. What's a standard presentation? We've had this over many years where there's groups that are not, quote unquote, having standard presentations because they weren't included in the original data generation. So you could have somebody who comes in with a presentation that's not standard, but it's standard for them. And the question is, who's being included as you're developing these algorithms? One of the biggest concerns from my standpoint with the AI point is, are you including everybody in there, accounting for the fact that there's different presentations for different individuals from different groups, and then also using the benefits? So that's my biggest concern.
Okay. Dr. Richard Allen Williams, why are Black women the highest in the world? In the world, you said. Why do they have the highest rates in the world?
Before I go to that question, can you hear me?
Yes.
Well, before I go to that question, I'd like to be able to comment on some of the things that were just mentioned very
Absolutely.
briefly. For instance, in regards to AI, I think that it's absolutely correctly stated that we have to be careful of the algorithms that are developed because of the fact that we don't know who is loading those algorithms and who's preparing those programs, whether they have that implicit bias that has been discussed that will actually turn those algorithms into platforms that increase the level of discrimination against people of color. So we have to be very careful. I don't think that the situation has been worked out to the extent that we can absolutely depend on AI to solve or resolve many of our problems with diseases and conditions that affect ethnic and racial groups. The second thing that I want to mention is in regards to what was discussed about what I will call a dichotomy or potential dichotomy between genetics and heredity and the environment. What goes to the old argument of nature versus nurture in regards to causation of disease and aggravation of disease conditions. We now know that what is called the social determinants of health, or SDOH, is really a much larger factor in regards to disease causation and propagation than what we previously thought was the biggest problem, which is access to treatment. And so it's important for us to recognize the fact that SDOH must be considered in all of our determinations and attempts to resolve problems. And such consideration is being given now in the new PREVENT recommendations that are moving forward. Bear in mind that those SDOH recommendations have not been fully implemented in those recommendations yet, and that this is a work in progress, which we expect will be very, very beneficial to the populations at need. And finally, I wanted to mention that we are still attempting to climb into a situation of real equity regarding healthcare delivery. And so we're constantly fighting behind. We've gotten indications from all of the speakers today that we have a lot of catching up to do in regards to doing things like making certain that high blood pressure is controlled. And we're constantly developing new approaches there. One of the approaches that I want to point out as a practical matter that we need to know about is something called RTP, or Release the Pressure program, that has been developed under the American Medical Association and the American Heart Association. And many groups are part of this RTP program, which is aimed at trying to control and reduce blood pressure problems in Black women by having Black women being involved in their own health care and trying to bring about blood pressure control and signing a pledge to do so. This program is tremendously successful, but it's flying under the radar. It needs to be better known, and people can look it up by simply going to rtp.com and looking it up. There are many hundreds of thousands of pledges that have been signed over the past 3 years that this program has been in effect. So that's something that's of practical significance in regards to trying to resolve this problem of high blood pressure. And it gets me back to the question that our moderator has asked, and I'm going to finish up with, and that is that high blood pressure being so excessive in Black women is not necessarily surprising, since Black women have been bearing the brunt of the assaults on our minority populations for centuries. And I strongly believe that that is one of the reasons that we see so much hypertension in Black women. They have been the bulwark of the efforts to maintain our survival in this world, and they're suffering the consequences of that. The Black men are not exempt from that either. there was a concept that was developed called John Henryism many years ago, which I won't go into details about, but anybody who knows who John Henry was, as a strong Black man who suffered a heart attack and cardiovascular collapse, essentially, after working on the railroad and trying to maintain himself in good health for years, failed to do so because of the stresses that were placed upon him. So what I'm saying is that we have to give some credence to the idea that being a person of color in this world, in this society, is extremely important for us to consider as not only causation of hypertension and other cardiovascular problems, but also aggravation of these problems. And we need to set our sights on attending to that.
Okay, and I would just like to add the intersectionality of race, gender, and class likely concentrates the stressors experienced by Black and Latino women especially, but certainly in raising children by themselves because of, certainly the incarceration of Black men at high rates has had an effect as well. Sharon.
Thank you. Is it on? Hello? Is it on? Good morning. Thank you. I want to thank you gentlemen for just an excellent, excellent presentations. And Maya, I want to thank you for co-hosting this forum. I am a health advocate by avocation. I am part of the Black Women's Health Study. I always thought of myself as pretty much healthy. And I never would have thought of myself as being on this screen. But in October, I had a quadruple heart bypass. In April, I had a stroke. And of course, I had high blood pressure to begin with. My questions, and I try to eat right, except on Thanksgiving, Christmas, 4th of July, my birthday, and some Sundays. My questions are for Dr. Rodriguez, because I'm Black anyway. Dr. Rodriguez, you talked about blood pressure being controlled. Those of us who are on blood pressure medicines, we take a pill and we're thinking we're controlled. We're curing ourselves, we're healing ourselves. But it sounds like that's not necessarily true. So my question is, what does controlled mean? And the second question is, Maya introduced you as a person who prevents cardiovascular disease. Now, that's not on my health insurance form. It doesn't say you can go to the person who prevents cardiovascular disease. How do we even get to you or someone like you with that title, with that goal, without already being sick?
Wow, great question, great points, and I hope you're doing well and better. I mean, in answering you, I also want to highlight what Dr. Ndumile mentioned about the holistic approach to treating a person, and that is that it's not just addressing your blood pressure number, but also trying to speak with you as a patient about the environment, the challenges you face, and what can be done to mitigate your risk by addressing some of those challenges, and by you being aware of what those challenges are so that you can take action. It's really a holistic approach, not just a pill and treating a number. To that, I will also add that one of the things that has been taking a greater stage in the blood pressure guidelines is, what is your blood pressure outside of the office? So one thing for patients like yourself is to know your numbers, not just when you go see the doctor, but also when you are at home, to be able to measure your blood pressure, to know how to measure your blood pressure. Again, taking action to mitigate your risk factors, and knowing that there are things in the environment, maybe challenging situations, people tell me that their blood pressure, their blood pressure only gets high when they get upset. But how many times are you getting upset during the day? How many times are you experiencing road rage or maybe an argument with a family member or what have you, or these things multiple times will impact your health and will impact your blood pressure control. So I think it's more of taking action and taking more ownership of your health through these means.
No, I think that was great. The only thing I would add is our target in terms of a number is usually for that top number to be less than 130 and that bottom number to be less than 80. But as as Dr. Rodriguez has mentioned, the psychosocial stress and all the other challenges, that's very real, and that has a very real impact on this. But I think as we've shown, it's definitely addressable. I'm a preventive cardiologist as well, and almost every healthcare plan can now allow you, if you have any risk factors, to be able to see a preventive cardiologist as similar to a routine physician. So that's actually available to everybody at this point.
Is there a question over here? Okay, yeah. The gentleman, we see you, but there's also, okay, great. Okay, no, stand back.
Hello. Okay.
Hello.
Hi, afternoon. Hi, Dr. Cummings. My name is Jay Rickes. I'm a research engineer, and great presentation. I'm just, I'm trying to consume it all in. But like my dear brother Jay-Z, I'm not nervous. I'm going to speak the truth, as I see now. I'm committed to ensuring that this country has definitely the STEM workforce to fulfill a lot of national goals. But of course, your health has to be optimal, to even think about digital skills. And I think particularly with the Latino population, new net workers by 2030 is going to be 78% of Latino workers. But I'm just curious, why is it difficult to create a national crisis when it comes to Black and brown folks getting access to therapy, access to being diagnosed, if we know that the economy is going to be built on Black and brown folks in just a decade?
Who wants to take that? Dr. Richard Allen Williams, did you hear that?
I'm not sure I quite understood the question.
Do you want to rephrase?
What's the bottleneck with declaring a national crisis for particularly Black and brown folks who are going to be the workforce of the future?
So he's asking what the bottleneck is in declaring a national crisis around this issue, given that Black and brown populations are a growing percentage of the national population.
If you ask me, I would say that it's because of what the obvious thing is, that we are, as Black and brown people, are devalued in regards to our value to society. And even though we're coming up in regards to recognition of our importance in the economy, we haven't quite gotten there yet in regards to that recognition. We need to emphasize through programs like this to the world, to society, that we are not only an important ingredient, but perhaps the most important ingredient as Black and brown people in the coming times, as far as our economy and its function is concerned. And so people need to understand that there is a business case for trying to create healthier situations for the people who are going to be the basis of this economy for the future, and get on board with trying to remedy the situations that are present right now. So what's being done now through the Bloomberg Center with this program is right on time and right on target in addressing this.
Very good. Sir, yes.
Can you hear me?
And there's another woman over here in the blue jacket who would need a microphone after him. Yes, we can hear you.
I'm Hassan. I study MPH at the Bloomberg School of Public Health. My question is two parts. The first one is, we know that, especially in cardiology, that ethnic minorities or different ethnicities respond to different medications better than others. So how much progress did we go in terms of identifying what medications work with different ethnicities? And the second thing is about the management and the social determinants of health, and the concept of social determinants of health, as good as it is, it's made based on British civil servants, while ethnic minorities tend to have more overloaded system, as you said. So how far also are we in terms of making models that fit more of the variability between us in the different ethnicities, and also to reduce this implicit bias, so treat the patient, not the symptoms?
Who wants to take that? Mhm.
I can address that to some extent.
Go ahead.
Um,
Okay.
I think that I understand what the gentleman is asking in regards to the importance of the social determinants of health in making a difference, so to speak, in what we're trying to do to bring better healthcare delivery to people in need, and especially to minority populations. I would like to point out the fact that there's an expression that's being used now that perhaps our geographic code is more important than our genetic code. And what that means essentially is that when you take a look at geographic location and bring it down into consideration, for instance, of zip codes, you find that you can actually predict disease occurrence according to where people live in a particular vicinity. For instance, if you take a look at a city like New Orleans, you find that people who live in certain zip codes there have a higher incidence of hypertension and other serious diseases, as opposed to those who live in more affluent zip codes. And so what this comes down to is applying the principles, looking at the social determinants of health, because of the fact that when we talk about SDOH, or social determinants of health, we're talking about the environment, we're talking about transportation, we're talking about child care, nutrition, all of those factors that go into making a difference regarding health care and health status for those individuals. So we must keep in mind that the SDOH principles have to receive a higher level of acceptability and give them much more attention that they deserve.
Okay, so we're running out of time. We're out of time. So the last quick question, and then we're going to close.
So hi, I'm an Archer Fellow with the University of Texas Systems.
Hi,
Sorry.
Michelle.
I had a quick question. It's like a two-part question, but basically, so an insurance company recently got sued for denying hundreds of thousands of claims in a small amount of time using AI, and you said that you were a preventative cardiologist, so this would come right under your alley. At the same time, a lot of AI in medicine is not being regulated by the FDA because it's, quote, assisting physicians and not listed as like a medical device. So what would be the role of physicians in your perspective for the use case of AI in medicine?
Yeah, so this is one of the areas where I would say gives me pause, because there's a difference between the idea of building AI into a clinical algorithm to make sure everybody who has a certain blood pressure, have you followed an algorithm to intensify their blood pressure medication, and then having an AI situation that is for an insurance company to say, can we find some reasons to be able to not support certain therapies or not support certain individuals or deny certain claims. So that, obviously some of that reflects the bias or the perspective of who's developing the algorithm and why they're developing it. I would say certainly from the standpoint of clinical operations, we've said that we don't think it's quite prime time because we really do want to make sure that the biases that go into that are being addressed. I would almost certainly say that if it's at the insurance company level and denying claims, as a person who fights with insurance companies on a relatively frequent basis, I would be more concerned about their motives and would say that AI could be misused in that situation. So those are my thoughts.
So my bias is to let us build it. Let us build it with the parameters we need, and then fight on Capitol Hill to get truly universal health care where no insurance company can deny based on what your status is. That being said, I have to close this panel. And I just looked at this book, and it's a Black history book, but it says, dream like Martin, help like Harriet, fight like Frederick, speak like Sojourner, invent like Madam C.J., write like Langston, dare like Rosa, create like Quincy, inspire like Maya, lead like Barack, and I want to add, research like Richard, Carlos, and Chiatti. Let's give them a hand.
I'd like to give you a hand as well. You excellent moderation.
Us and our moderator, thank you so much. We are going to shift to our second session in 5 minutes. Let's take a quick stretch break, and then we're going to switch to our second part of our time together this morning. Thank you so much. We'll resume in 5 minutes. Thank you.
That was great.
Started in about a minute, please. We're gonna get started in about a minute. Thank you. Yeah. Thank you. Sure. All right. We're going to go ahead. I'm only going to briefly just announce our next session host for our fireside chat. And just, I hope everybody's inspired from that first session. It was fantastic. And I hope that everybody's embracing the words from Dr. Gaskin, who talked about having a seat at the table. And I remind us all in the honor of Black History Month of Shirley Chisholm's famous words that said, if they don't give you a seat at the table, bring a folding chair, right? So I want to remind us all to know that our places are at the table. So I want to just go ahead and turn it over to our host for today's fireside chat, the award-winning journalist and best-selling author, Mariano Atencio. All right, thank you. Thank you. Thank you.
Good morning, everybody. Buenos dias. Can you hear me okay? Buenos dias. How are we doing? So I am so honored to be here today. I would like to begin by thanking the powerhouse that is Dr. Maya Rockymore Cummings for allowing me the opportunity to host this conversation. Maya, where are you? Right, you're here. This event is such a testament to your commitment to empower and lift our communities. So thank you from the bottom of my heart. Marco Davis, where is Marco? Right here. Marco, thank you for what you do for CHCI, for your continued partnership, and for fostering the next generation of much-needed Latino leaders. So, ladies and gents, I am originally from Venezuela, and I don't have to tell you the scale of the health and humanitarian crisis that I've experienced in my home country. In addition, my experience in global journalism has allowed me to cover stories that span continents and cultures in places like Haiti and China and the Syrian border in Mexico. And continually, I've interviewed everyday people in these places and seen the effects of not addressing health disparities when it comes to cardiovascular diseases firsthand. So it affects every single person on this planet, as we've seen in one way or another. But the fact that it is the #1 killer of men and women, especially Black and brown men and women in these United States, is simply unacceptable. We are here to say enough. We are here to push for policy change, especially during Black History Month. We are here to say we can do better. So with that, I am going to introduce our second panel. Let's get to the heart of the matter, how the social, the environmental, the economic, all of the social determinants of health exacerbate cardiovascular hypertension and the stroke crises. And we have garnered some of the leading minds in this field. I'm going to briefly introduce them. Their titles, I want you to give them a resounding applause. And then I actually would like each of you to expand a little bit as to why you're passionate about this subject matter and your involvement in it. So let's begin with our gentleman, Dr. Eduardo Sanchez, Chief Medical Officer for Prevention for the American Heart Association. Un aplauso. Dr. Nadine Gracia, President and CEO, Trust for America's Health. Thank you. And Dr. Elena Rios, President and CEO of the National Hispanic Medical Association. Thank you very much. I'm going to ask all of you to take a seat. I don't want you to be shy in talking a little more about your trajectory in this field. Actually, Dr. Rios, I'm going to start with you since I introduced you last.
Okay. So I'm Elena Rios, President and CEO of the National Hispanic Medical Association, which represents the interests of 50,000 Hispanic doctors around the country in the United States that are licensed. And also, I'm president of the National Hispanic Health Foundation, which was started as the philanthropic arm of NHMA. It was actually called the NHMA Foundation back in 1994 when we started. And just to let you know, we're celebrating our 30th anniversary. We're very proud of being here for 30 years in Washington. And I guess just to say a word about what we do in public policy and the relation to social determinants of health in our communities is we believe in having the voices of Latinos who've made it in the professions, not only doctors, but nurses, dentists, pharmacists, et cetera, to be showcased in this country's policy world as leaders who come from our communities. We're the first generation to have gone through college and medical school in this country. And it was in 1993 that I came to the White House and decided with a group of doctors that we should start our own network. We call it our National Hispanic Medical Association. We're all about helping our communities. The goal of our both organizations is to improve the health of Latinos and other underserved. And we work with everyone here in Washington that we all believe in the same, I think, ideals, that it takes us to make the change.
Thank you for that. Dr. Gracia.
Thank you, Mariana. It's wonderful to be with all of you today. Thank you to Dr. Rocky Moore Cummings for the invitation. My name is Nadine Gracia. I'm the president and CEO of Trust for America's Health. We are a nonprofit, nonpartisan public health policy research and advocacy organization that's headquartered here in Washington, D.C. We advocate to really advance evidence-based policies that are going to promote optimal health for every person and community, and where our vision is that we will be a nation where prevention and health equity will be foundational to policymaking at all levels of society. Among our policy priorities is obesity and chronic disease prevention, and so hearing the previous panel in particular speaking about obesity and other chronic diseases as risk factors and contributors to heart disease, cardiovascular disease, are areas that we focus in on. Mariana, you asked us to also share a little bit of our background and why we are passionate about this work. For me, it stems from my family. I'm a first-generation Haitian American. My family is from Haiti. Thank you, Mariana, for the work that you have done in my family's home country. And I know the investment that was made in me to have the opportunities that I have here in the United States. And I also see, and from being a very young child to now, the way in which we've had fragmented and broken systems that lead to the inequities that we have been describing, that cause communities to not have the opportunity to be as healthy as possible. So my passion stems from my family, and prior to being at Trust for America's Health, I was in the Obama administration as the Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health at the U.S. Department of Health and Human Services. So that was our charge, was how we advance health equity and reduce racial and ethnic health disparities in the nation.
Thank you so much for your service.
Good morning, everybody. My name is Eduardo Sanchez. I serve as the Chief Medical Officer for Prevention at the American Heart Association. There's a few of you who know me, and you would not believe I'm a little nervous right now, so
relax.
Bear with me. I work for the Heart Association. It is an organization that has as a mission statement to be a relentless force for a world of longer, healthier lives. It is a mission statement that has afforded us the opportunity to move from thinking strictly about the science of what happens in clinical care settings and beginning to think about and address the very issues that affect one's ability to achieve optimal health, to achieve the best outcomes. I will cite three just recently published papers, one not so recent, but very germane to the conversations that we're having. One is a very recent publication addressing structural racism through public policy advocacy. Hopefully I can talk a little bit about that paper. We've also put out a scientific statement about assessing and addressing cardiovascular health in LGBTQ persons. And then just before the pandemic, we released a scientific statement on a call to action to address rural health. We are an organization that has made one of its calls to action that we are champions for health equity, and I'm proud to be on the stage with you guys to talk about that. My personal journey, I am a first-generation U.S. citizen. My parents are from the Dominican Republic. I spent every summer of my life as a kid in the Dominican Republic, and it broadened my sense of what is, what could be, and what should be. And I would say that one of the lessons learned from my very extended family is it is not enough to just be in a place, we all have to give back to the places that we are part of, and I carry that to the work that I do now.
Thank you so much. It's a pleasure to have you here. Un placer. So the format is going to be a little different. This is obviously a fireside chat. I want this to be conversational. Feel free to jump in. And I love you guys' energy in Maya's panel, so please keep the energy coming. I'm going to open it up for Q&A right after we finish the fireside chat portion. So let me begin, and Dr. Gracia, I'll start with you on this question. Why do our Black and Latino communities experience such high rates of obesity in America? And the numbers are stark. We're talking about 49.9% in the Black community, 45.6% in the Latino community.
Thank you, Mariana, for that question. Is my microphone on? Yeah, okay. Thank you. So let me take just a step back in really talking about the trends of obesity in particular. Our organization publishes an annual report called the State of Obesity Report, and last year was the 20th year of issuing that report. And what we have seen is actually across the U.S. population, we have seen rates of obesity rising, both among adults and children. Among adults, obesity rates rose by 37% over 2 decades, among children by 42%. What that's pointing to is that this is a population-wide public health issue that we must address. But what we also see, just as to what you were pointing to, is that there are significant racial and ethnic disparities that exist in obesity. Obesity is a complex disease, and I appreciated the panel earlier talking about when we talk about these conditions, it's understanding not putting blame on the individual, because obesity is a complex chronic disease in which you can look at factors certainly of, yes, looking at biology and genetics, but also importantly, the social and economic conditions in which people are born, where they live, where they grow, where kids play, where people age, that influence our risk for developing these diseases, as well as thinking about the quality and access to care to be able to prevent and manage those diseases. So when we think about the disparities in obesity, especially as it relates to race and ethnicity, we need to really examine as well the social and economic conditions and what everyone's been describing as these social determinants of health. Understanding that everyone is influenced, everyone's health is influenced by where you live, where you grow up, where you play, where you work. But the issue for far too many communities of color are the inequities that exist there, that there's an unfairness with regards to not having access to healthy and affordable and nutritious foods in communities. Some communities that don't even have a full-service grocery store to be able to access fresh fruits and vegetables, or communities that the built design of the community lacks walkable paths, biking paths, playgrounds, parks, and other aspects that promote healthy living through walking and biking and other forms of physical activity. Making the connections as well to economic opportunity, where we can look at the studies and literature and data that show when you have higher incomes, when you have higher educational attainment, you have higher health status. But yet we see and we look at, and I'm sure that Dr. Sanchez will speak about this when he talks about the American Heart Association's work in structural racism. When we look at the long-standing impacts and enduring impacts around, for example, redlining, which really caused a disinvestment in communities, that disinvestment leading to less resources of economic opportunity, of quality education, of access to health care and healthy foods, that then places greater risk and higher risk for these types of conditions. And then importantly, in the previous panel spoke to this, the stressors of this, the stress of discrimination, the stressors of structural racism. Again, these have physiological effects that also can create and exacerbate these types of disparities. So it's a complex disease, but that complexity does not mean that we don't need to take action to be able to address and reduce those disparities. And we have programs, policies that actually work. What we need is the leadership, the will, and the investment to actually ensure that everyone has access to those opportunities.
And we'll touch on structural racism. Before, Dr. Rios, I want to go to you. What are the social, the economic, and environmental factors that you have seen are exacerbating the obesity crisis?
Well, I think Nadine already discussed many of the factors. I'll just talk about the Latino reality. In our communities, we have very strong family values, and that means celebrating and having great food every Sunday night. That's part of the problem. The other part of the problem is our cooking and what we use for cooking. And I think it's important to realize that we need to have recipes that are more heart healthy. We often have very much traditional foods that are cooked in the wrong way. And I'll just give an example: corn tortillas versus flour tortillas, white rice versus brown rice. So that's part of the traditional issues. The other cultural issues, I think, are very positive, that we have very much social interactions and social supports in our communities. But what happens when, young men and young women in high school start having identity problems? We have a lot of problems in this country with acculturation and generations. I'm third generation Mexican American. My parents, wanted us not to learn Spanish because they wanted us to get ahead and go to college. My dad was a factory worker. My mother actually went to college and became a nurse after having 5 kids. But so many of our families in poverty have this notion that, that you need to just go to work or get married. And there's so much stressors with the identity. That's the traditional identity. And our Western identity, or United States identity, is that you should do things for yourself and be more greedy, more selfish, and not take care of working with the family and helping everybody else. So I think part of the obesity issue is letting all the stressors get to you and not taking care of yourself, and not spending the time to do physical exercise, not spending the time to understand what healthy diets are. Very basic change is needed in our communities. And I think that the issue that was brought up earlier about looking at young people and how to change education in our schools means having, I've been in the Southwest, I'll just say in Arizona, with school teachers and administrator types, supervisors, leadership meetings where the Latina supervisors of school districts will say, we can't expect our kids to go to medical school. And here I am talking about the importance of getting into health careers. And we have our own people thinking that we shouldn't even bother raising the expectations of our young people because they're stuck in their rut of thinking that it's a cycle of poverty and they're never going to get out. Those are the kinds of stresses that we have among ourselves. And people don't realize that we really have to have more policies developed by leaders who come from our own communities that understand the strategies that we need to change things. And it's very personal, and it's also very grassroots. It's not just one policy changes everything. The school districts need to have counselors and supervisors that are very much people that will encourage the young students to get ahead and not to discourage them. And I know from many, many Latinos that have gone into medical school that they were discouraged from day one. And they did it because they understood the importance of math and science, that they were competent in it, and not because of their counselors. And also our parents. Our parents don't understand that you have to go to college for 10 years to get to be a doctor, and it takes a lot of investment. And what they think is that it's going to cost too much. And the financial stressors on our families are horrible. So anyway, I'll just stop there.
Thank you for that. It's a lot to take in, but it's the reality. I'll just add a personal anecdote from my journalism experience that came to mind when it comes to the Latino community specifically in terms of the environment. I covered the whole battle to add the question of citizenship in the census. I don't know if you guys are familiar with it, but it prevented a lot of Latinos from filling out the census. And what that does is that it prevents funds then to be allocated to our communities for those parks, right? For those hospitals, for all of the elements that we really need in order to have these diseases not affect us. I'll now take it to you, Dr. Sanchez. These social determinants of health, we have heard about them this morning. Why are they important in terms of policy change? What can be done in that realm?
social determinants of health are important in the policy realm because they are the levers, they are the opportunity to change the way things are. And I would say to you, one of the things that I want to remind y'all of when Dr. Ndumale showed the graph with the differentials in cardiovascular mortality rates, and I think implied, if he didn't make this statement, that's unacceptable that there are those kind of differences. I want to take you to a topic that Doctors Rios and Gracia have talked about. It's educational attainment. There is an unacceptable disparity in high school graduation rates in the United States of America. And if we compared, and we showed it on the graph over there, the graduation rates for white students and Asian students in this country are up here. Never mind the challenge of disaggregating what's in that category called Asian, but by and large, even lumped together, graduation rate is high. Let's call it 90%. And the graduation rates for young people who are Black, who are Latino, who are American Indian or Alaska Native is at a level of 75% to 80%. Too low, we've got to do better. We've got to commit ourselves to doing the things that have gotten us to the point of saying it is unacceptable that there is disparity in health care. We should reach the point to say it is unacceptable that there is disparity in education. What policies can we take on? One policy would be to undo the differential pupil funding formulas that exist that are based on local tax bases. So if we think about what Dr. Gracia talked about, where you have localized or centralized or concentrated poverty, that concentrated poverty results in low tax base and the inability for a school district to pay teachers the same that they might pay in that neighborhood down the road. Remember, Dr. Owens talked about New Orleans and the difference in mortality rates and life expectancy. I guarantee you that if we look at educational attainment by zip code, same thing, a disparity that we should find unacceptable. I'm going to talk in that. So that's one policy, one area of policy, and there's an abundance of work that's been done that says, how can we help make that happen? One very clear way is universal pre-K for young people. The degree to which a person enters kindergarten with the ability to reach third grade at or above reading level is a predictor of graduation high school rates. One way to do that, the evidence is abundantly clear, universal pre-K, that makes a difference. Another evidence base is high school completion support. What does that mean? It means you have an underperforming student, you provide them with the attaboys and attagirls, and they will graduate. So Dr. Rios, one other thing where there's evidence is, the evidence is that if Mariana is being told by lots of people, si se puede, you can get this done, you can do it, compared to Dr. Gracia not being told that, all things being the same, Mariana outperforms. So we need to get behind a we can do this, si se puede mentality. Then the last area of policy, there's many. And again, I encourage you to have a look at the Addressing Structural Racism Presidential Advisory. It talks about policy change in 8 areas. Access to health, which I'm going to talk about here in a second. Education, I talked about it a little bit. Healthy food and nutrition security. Oh, I forgot. There's another paper that we put out, a scientific statement on nutrition security that came out about 3 years ago that speaks to the policies that might ensure that whether you are a young kid in school, you're getting foods that will fuel your brain and help you think better, or you're in a family of low household income that can feed your kids and and the parents both. So health, food, education, income, and capital. Income is important. wealth is important. Having $1,000 in the bank to take care of your broken car is the difference between being not able to go to work and being able to go to work. And then environment and housing are two other of the 6 primary areas, but also funding for public health and also civic engagement. And I want to focus there, and I'm going to come back to health. Civic engagement is the idea that we all ought to be playing a role in the policy changes that can and should be taking place at the local, state, and national levels. And the evidence is that that is a predictor of neighborhoods that do better compared to neighborhoods where there isn't that kind of civic engagement. We can collectively work to create the capacity to do that in our communities.
And we'll touch on that.
Healthcare, let me do
Go
2.
ahead.
2 concrete things. 1, expand Medicaid in those states that have not. There is a disproportionate percentage of persons who are black and brown, particularly in Florida and Texas. Those 2 states represent 2/3 of the opportunity that can be achieved by expanding Medicaid. And one other call out would be to expand the number of federally qualified health centers in all of our states, particularly those that have not expanded Medicaid. FQHCs by design are there to serve people who are low income, uninsured, underinsured, provide primary care, dental care, mental health care comprehensively. We need more of them.
You touched on many points. Se te fue la pena.
He's
not nervous
la
anymore.
lengua.
He's not nervous anymore. I want to.
It takes a while.
Takes a group of 3 women on stage. I'm going to piggyback off the Medicaid question first, or point, because it was the last thing you touched on. Dr. Gracia, some states expanded Medicare coverage when Obamacare was passed. After seeing decreased rates of obesity and heart disease in those states that expanded Medicaid coverage versus those that did not, is Medicaid expansion by itself enough?
So I think what we're, and even inclusive of the first panel, it's to show, as we talk about promoting health equity and addressing health disparities, we have to address this across all sectors, because the issues of inequities are pervasive across every sector: healthcare, public health, education, housing, transportation. So Medicaid, in providing access to coverage and care, is one of the pieces and components of that. There's not just one solution and step. It's why all of us have a role to play. It's not only for the public health sector or the healthcare sector or education, but it's all of us. It's employers all taking a role to understand that this is so pervasive in our society and really cuts across the various sectors, that in order to address this, we have to actually work in collaboration to do so. So yes, you pointed to the fact that with Medicaid expansion, in states that have expanded Medicaid, we have seen increased utilization of preventive services, increased access to care. These are important measures to denote, are we truly promoting the health of communities and populations? In addition to that, we also need to look at, and Dr. Sanchez alluded to it, the investment in public health and prevention. We spend as a nation $4.3 trillion annually in health spending. Only about 4.4% of that is for public health and prevention.
Can you repeat that, please?
4.4% of the over $4 trillion that we spend as a nation goes to public health and prevention. And when you compare the U.S. to other high-income countries around the world, we spend the most when it comes to our healthcare spending, but if you look at our health outcomes, it's not translating into better health. We have the lowest life expectancy among the high-income nations. We have highest rates of maternal mortality, infant mortality. We have high rates of chronic diseases. We have to invest in public health and prevention, and I appreciated the previous panel talking about this in the context of thinking about risk for cardiovascular disease, why we need to think about our youth and young people, that there's so much that can be done when we think about prevention and primary prevention with our children. And Dr. Sanchez alluded to this, which was looking at our schools, access to healthy school meals in schools. there are efforts that can be taken both at the federal and the state and local level to provide the environments that actually promote health, access to healthy nutrition, access to physical activity, but also being assuring access to educational attainment, because that is a strong predictor with regards to health status and health outcomes.
And of course, it goes without saying that when you talk about us as a country having the highest rates of maternal mortality, of course it is Black women who experience the highest rates. Dr. Rios, over to you. We've touched on the policy changes that need to happen, not only federally, but what can state and local governments do in order to address this?
Well, I think the state governments and the local governments are all part of public health. The public health system in this country, I think, just went through a very historic pandemic. And one of the grants that we got at the National Hispanic Health Foundation was to start looking at diversifying the public health workforce and also expanding the public health workforce. And I think that's one thing the states, not only CDC at the federal level, but the states and the local communities need people that understand how to get to the community, because as was also stated earlier, 20% of medical care, is responsible for all the problems that we have. It's really the community level, and which is public health. The community level programs need to be expanded and supported to be able to educate people on healthy lifestyles. People that are in the uninsured populations and underinsured populations are minority people, Latinos, Blacks, Native Americans, do not have access to health care. So why would we keep spending more money on educating through the hospitals and medical systems, healthcare systems, when we're not reaching the population that really needs the information? So I think that that is the focus of the more local and state level public health prevention programs. And like Dr. Gracia said, I mean, it's ridiculous that this country doesn't spend the money on actual information exchange and sharing of information through the federal government's funding that actually funds the states, or Medicaid waivers from the states that can actually be more creative in using more funding for prevention and public health. So I'll just stop there, but I think that that's what's important, is that there is a whole movement now because of the pandemic to understand how do we get better care and better information to get to the care for people that are what we call essential workers, that were the ones that had the most problems faced during the pandemic.
So obviously, we do not live in a vacuum, and this has to be addressed. We are going through a time where some are pushing for colorblind policies. If successful, what effect would this movement have on these efforts to close disparities by pushing for health equity in public policy making? Dr. Gracia, I'll start with you on this one.
Well, I think if I would take the question and actually say, what do equitable policies actually lead to for the nation? And it's showing that both there's health evidence and economic evidence of how, when you have intentionality around policies that center equity, you can actually improve health. You can also actually reduce health care costs. We just talked about the rising health care costs for the nation. And so when you look at some of the policies that we've been describing, whether it's access to universal pre-K, if it's access, for example, to the National School Lunch Program and increasing those who have access to it, the Earned Income Tax Credit, which can lift families out of poverty, improves maternal health and child health, but also helps increase labor force participation. And when you look at the populations that are disproportionately impacted by not having access to this, they are communities of color. And so when we think about this, by not centering equity, we are exacerbating really the health crises that we're having in the nation, and we're actually not reaching the full potential in terms of the potential of the people of this country, but also our productivity as a nation. And so from our vantage point, as we work to educate lawmakers and policymakers, we have to present the justification in so many different ways. You know, what appeals to that policymaker may be the data. In some cases, it is the stories, especially from, the communities, their constituents. And in other cases, it's looking at the economics. And so for us, if we can't really go back to what we were pre-pandemic and say we can just continue with the types of policies and structures that we had prior to the pandemic, because this continued to exacerbate the inequities that we're seeing across the nation. What we actually saw, especially in the height of the pandemic with regards to some of the emergency legislation and policies that were implemented, we actually saw that we can address these issues. We can provide free school meals, universal school meals, healthy school meals to all children, because that's what we did in the pandemic. We can provide tax credits because that's what we did to ensure that that families that were lower income had those provisions, or paid sick leave, so that you didn't have to make the choice between, do I go to work while I'm sick, or do I stay home but then I risk losing my job? And we know that workers of color, Black and Latino workers, are less likely to have access to those types of economic and employment benefits. So I think that part of our framing is why we must center equity for the optimal health and well-being of the nation, and utilizing the various approaches to explaining not only the health evidence, but also the economic evidence that it has for the nation.
And you touched on 3 points which I think are critical to cut through the noise: data, stories, and focusing on the productivity, because those are undeniable. Dr. Sanchez, on to, what are structural solutions to structural racism, and how can this agenda be achieved?
Thank you for the question. I am somebody who, for many years in the different roles that I've played, and one thing I didn't share is that I had the privilege and honor of serving as the first and only Latino Commissioner of Health for the state of Texas. My charge was to, thank you, my charge was to lead and serve. And I can't tell you how many times, whether it was in a restaurant or walking through a parking lot, where I had Latinos, people who were working class folk, people who were the essential workers, coming up to me and would say, ¿Eres usted el secretario de salud? Yeah, I'm the Secretary of Health, and a pouring out of pride. And I think that sometimes we forget one of the things that's so important about a panel like this is putting people like Dr. Rodriguez and Dr. Gaskin and Dr. Pollack so that others can see that si se puede, it can be done. If I did it, you can do it. So that's an aside. Structural solutions. I'm a believer that we should leverage those things that are in place and make them work better. So when it comes to Medicaid expansion, as an example, we don't have to figure it out because that thing already exists. It literally is flipping a switch. And those states, even the ones that haven't expanded Medicaid, provide a little bit of Medicaid. And I want to be clear, it's just a little bit of Medicaid. But FQHCs, they exist. There is a framework through the Human Resources and Services Administration and support from the National Association of Community Health Centers to make that happen. We talked about healthy foods in schools. There are programs that are the feeding programs. I hate that terminology, but they are the programs that help provide nutrition to young people. So bad me for saying it, and now good me for correcting myself. Provide nutrition for young people that don't have to think about, can my family afford my breakfast and lunch today? Leverage that. WIC, the Women, Infants, and Children program, it exists. How do we maximize the potential of that infrastructure that exists? And let me be clear, it's not either or, it's and. But let's leverage those opportunities so that we can make best use of what's already there while we try to create the innovations and the new approaches and the different ways of complementing those efforts.
Mariana, if I could
go ahead,
please.
Just
say in response to what Dr. Sanchez said about, leveraging what's there and what works. I mean, that's what's so important is we have programs and policies that we know work. And as an example, when we think about nutrition and physical activity, there's a program called the State Physical Activity and Nutrition Program, SPAN, that is awarded by the Centers for Disease Control and Prevention to states across the country. There is only adequate funding for 17 states in the country. So when we talk about this disparity with regards to not having the adequate funds for public health and prevention, this is the impact. We're saying that obesity and chronic disease is an issue across the country, and yet we only have the funding for 17 states. Or looking at programs such as the racial and ethnic approaches to community health, the REACH program. That program, which is celebrating its 25th anniversary this year, that program, there's only adequate funding in the current grant cycle for 50 recipients. They have hundreds of applicants. We need these programs that have demonstrated that by having these tailored approaches, working community-based organizations, health centers, other health departments, working together to look at community planning, the urban design of communities so that you can promote physical activity, ensuring that you have, whether it's farmers markets or other ways that you actually bring access to healthy foods to community as opposed to expecting that they are, thinking about the infrastructure design that doesn't work for them. These are evidence-based programs that work, but we have not given the resources to be able to actually ensure that every community has the opportunity to benefit from those types of programs and policies.
You literally took the words out of my mouth with the next question, because I was going to touch on bright spots. There are programs that work. We just maybe not know about them, or there isn't enough funding to make them national. How are we doing on time, Maya? Do we have time for one more? And then audience question. So this question is actually for the three of you. Dr. Rios, I'm going to start with you. We have discussed, all of the several factors that contribute to cardiovascular disease and the federal, state, and local policies that can ameliorate that. But this is a disease that affects everyone. Everyone knows a loved one. Everyone here has a family member that has suffered from this. So what can people in this audience do, and those watching individually, to improve this scenario?
Well, I think the most important thing that we're talking about is public policy and getting to know your congressman and your senator, and having people in our local communities get more civically engaged, as was mentioned earlier. I think that's the most important thing we can do. And I'll just say, as an example, Dr. Rodriguez's policy recommendation to have a blood pressure control as a fundamental lifestyle factor, and at the young adult level, below the age of 30, not waiting until you're sick, but or feel sick, but actually as a preventive measure for people to understand in this country that blood pressure is so prevalent that we should have hypertension centers and a hypertension campaign more than has been done already. And I think it's because we don't have the support. And I think raising more awareness to our policymakers of the need for the country to have a better focus on cardiovascular disease would be by having the prevention messages.
Thank you for that. So prevention messages, civic engagement. Dr. Gracia, what can we do on the individual level?
I support what Dr. Rios shared. I mean, this can be done at all levels with regards to really raising your voice, and your voice matters, to really raise awareness of the need for this type of investment. There are still, even though we have gone through the worst pandemic in 100 years, there are still efforts now to actually cut funding to public health and prevention. Having your voice to say, what's the impact for my community if we don't have access to these resources is critically important. And also working in coalition and in partnership with others, because also recognizing the trusted voices of the community will resonate more. And sometimes we have to recognize if the health official or the government agency may not be the voice that should be sharing the message, but instead it's a community leader, it's a faith-based leader, and understanding that there's power when we work in partnership to be able to deliver these messages. There are ways in which, for example, we can provide the data, we can provide the evidence, but having someone who has the lived experience or someone that has been working directly in community and has the trust of community is a powerful messenger to be able to also champion these types of messages around, for us, public health and prevention.
Great point.
Use your individual voice and use the collective voice. So I won't repeat what has been said by Dr. Rios and Dr. Gracia, but I would say ask yourself also, where do I spend my time during the day, and what is that place, the organization, whether it's a faith-based community, the place you work, the neighborhood you live in, the school district your kids go to or your kids went to. What role is that institution playing in addressing policy opportunities, small p, that might get us to the kinds of things we're talking about? And one concrete example would be making sure that all employees have time off for medical leave, as an example. Have an appointment, you can take paid time off. Second example would be making sure that co-pays are as low as they can be, particularly for employees that are at the lower end of a continuum. And back to your question, though, those are things that if you work at a place, it's fair to ask those questions on your own behalf or on behalf of those that you work with. Single voice, collective voice, and couldn't agree more with Nadine that your individual voice is really important. I keep hearing over and over and over again, those elected officials count the number of individual letters that come their way, but collective voice is the way you can walk into an elected official's, or make an appointment, don't just walk in, but make an appointment to see an elected official and bring the voice of many to articulate with data and then with stories an issue that may catch one of those elected officials. And I think the last thing I will say, engaging with elected officials, whether it's by yourself or with others, is not a one and done enterprise. It is an enterprise where you have a conversation, and if they don't vote your way, don't hate them. Come back the next time, because what you are trying to do is to be a voice that can bring information to them, and they may not always vote your way. But when you get to the point where they are contacting you, you have now penetrated at least the first layer, the first protection shield that they have to not pay attention to information. They are now listening. Listening gets you to a place of being able to influence what might be the next decision.
Round of applause for that. I think that deserves a round of applause. Q&A, let's see, who wants to start? Over here, the lady over here in black. Can we get her a microphone? Great.
Thank you. Oh my goodness. Thank you for this important conversation. Thank you, Maya, so much for inviting me. I just appreciate it. I am standing here, you can see I'm a black woman, and so much of this conversation swirls around my health, and I just want to share with you all that for 40 years, I dealt with food addiction and morbid obesity, toggling back and forth over 700 pounds. I never weighed that much, but I lost and gained that much over 40 years. But my question and what strikes me in this panel and the panel before is we talk about all these health issues that are preventable. But it is the food supply. I mean, we can have access to healthy food and nutritious food, but if there's not desire for it, right? If there's not, and Dr. Grassi, you talked about the SPAN program, the REACH program, the limited funds for it. We've got processed food, fast food, snack food industry that has billions of dollars that creates desire for us to eat stuff that's not even food, that will kill us, that is killing us every day. And I didn't recognize this until I was on my own journey to even know the difference between what was real food and what was fake food. That you can be a food addict, but it's the processed food, but it's the real food, is the whole food, is the SPAN food, the REACH food that nourishes and heals us. And I just need a conversation about people having the education to understand that every bite is either going to kill you or heal you. And we're in an environment, this environment that we talk about, where we are taught and programmed to eat for pleasure, entertainment, and activity, and not nutrition. And that will save us. And I need somebody to, so I need that.
I'm going to jump in because I think it's really important. This is a group of folks who look like, and I've heard describe already, we come from very different, diverse backgrounds. And I would say to you that in the countries that your parents or you or your grandparents came from, obesity was not a problem eating the foods that people were eating when they were living in those countries. And I would say to you that the demarcation may indeed be the production of, the marketing of, the consumption of many, many processed foods. No one forces us to eat them. Couldn't agree with you more. But when you have that crazy bird telling you to go cuckoo for Cocoa Puffs, but you don't have a carrot telling you, eat me instead, the pressure that we experience as parents from our kids sometimes lean us towards the Cocoa Puffs and not the carrots. And it's multifactorial, there is no doubt. But when we look at even the recommendations that are made by the USDA guidelines, by the American Heart Association, you look at those foods, those are the foods that constitute the heritage foods of any of us who's living here. And what's not included are the foods that are in the categories that you talked about. So how do we, at the same time, embrace heritage as a value and begin moving us to eating more of those and less of those ones that you described as being overprocessed, very heavily marketed, maybe bringing pleasure. But the other thing, remember, I heard on both panels, there were people in the audience or on the stage who talked about the place of food as being one of the cultural values that is what we are. It doesn't have to be about abandoning those in the name of addressing obesity. It is about honoring those and at the same time thinking about those strategies that reduce the marketing, that make healthy choices more affordable and more available, and reduce the demand, some of it marketed and contrived for the quote-unquote cuckoo for Cocoa Puffs category of foods.
And if I could add to that, your point around the food system itself and the food that we have access to is so important. And thank you for sharing your journey. It's just powerful to hear your story. I would say there is such opportunity right now, especially to bring that voice into what's happening. I'll speak more specifically at the federal level. One is the actions, for example, that the Food and Drug Administration is taking around front of package labeling, which other countries around the world have adopted. We have not in the United States, really working towards, can we adopt front of package labeling that has been shown in other countries to actually change practices as far as when you inform a consumer, they actually are looking to identifying what are healthier foods, because then they can identify, oh, this has a lot of added sugar content, or this has a lot of sodium, salt in the packaged foods. Yes.
Important to add, those front of label will not look like the back of label that you need a PhD to read.
No, that's right. That's right. So we have the nutrient facts labels on the back, and even the FDA commissioner himself has said, gosh, you have to flip it over. I mean, are people really flipping it over? And then you have to understand, what does this all mean? Having a very easy to understand label that, again, using some of the models from other countries where it's kind of these like warning systems, whether it's a color-coded system or other systems, to make it simple for anyone to be able to understand and utilize that as a way to informing consumers. But the marketing piece that you also raised, that's another area. Not only is there heavy marketing of unhealthy foods, there are studies that have shown that those unhealthy foods are disproportionately marketed to children of color. So one of our recommendations is that we need to end the tax loopholes and the business cost reductions that allow that form of marketing that disproportionately impact our children of color to seeing those types of foods and actually not seeing healthy foods, for example. There are other efforts, for example, with regards to sodium reduction, sugar reduction in foods, trying to move the system to understand we have to move towards these healthier products to be able to, for consumers to have access to. many of these agencies that are doing this work, like the Food and Drug Administration, they're calling for comments and feedback. They need to hear our voice to say, this is important. We support you in this work that you are doing, because they're utilizing, whether it's the lived experience, the data, the researchers that are in the room, that you can provide that information. So understand that you don't have to be the head of the organization to submit comments into these agencies. They want to hear from academic researchers. They want to hear from those of you that are working in community organizations to say, this is why these types of measures and these changes with regards to policies that will help to improve our food system, and then you hope actually serves as a nudge to the producers to say, we've got to actually change, because if they're changing this and people aren't buying our products anymore, we've got to make sure that they're still marketable. The federal government has done that with regards to procurement and federal agencies, with regards to the foods that they'll allow in the federal agencies, in the cafeterias in those agencies. What can the private sector do similarly? So that's the part of this, is that competition and incentive to be able to change the food system and environment that we're also in. I'm really glad that you brought that point up. Thank you.
Thank you for that. And again, thank you for sharing your journey. And your accessories are incredible, by the way. One more questions. Let's see over here, the young lady.
My name is Brittany. Thank you so much for this wonderful talk. My question is targeted to Dr. Sanchez. And you talk a lot about all the paid time off, for example, for education, really addressing social determinants of health at its root along many levels. And Dr. Garcia, you also talked about COVID-19, how that impacted communities of color more. However, during that time, there was federal financial support from the government, which was sent to everybody in this country, and ultimately it helped to remove child poverty during that time. Despite that evidence, the government still retracted back its financial aid. And with that said, there has been evidence among all of these issues for several years presented to policymakers, but it hasn't really changed anything substantial with regards to healthcare. So that being said, I think part of the issues that our country is capitalist facing, and there are healthcare insurance lobbyists that overtake any actions that the individuals would want to change. And you all note that we should speak to our policymakers. However, with competing against health insurance companies, despite all of the research that's already existing, it seems almost infeasible to actually get things changed. So I would want to know if it's possible to use the support of American Health Association, Trust for America's Health, National Hispanic Medical Association to leverage the power these organizations already have and make a point to how important these issues are in the media, using your platforms to actually get that done. Because once there are grassroots efforts, Fred Hampton, Malcolm X, MLK, every time we try to do socialist changes that you're suggesting, for example, Dr. Sanchez, it's continuously shut down. So I think it is important to recall back and help get some support from Johns Hopkins and these other organizations to really use your platforms and make the importance well known in our media to get things discussed.
So, Brittany, that was amazing because you went beyond, you challenged us to, do more than just talk about stuff, and that's what I'm hearing you say. I would say that our three organizations, I promise you, are involved in some of that. I would say to you, there's a few things that I want to make sure I say. One, we've got to think short-term, intermediate term, and long-term. And helping people with poverty issues, as an example, in the moment is going to help their lives place in a way that we don't have a good way of measuring how much better it was that when the car broke, there was actually a little bit of money to fix the car. And our ability to measure that outcome, particularly through some of the health metrics that we look at, could be challenging. If we were to ask questions around well-being, we might be able to measure some of that. It's the reminder also that I agree completely with my colleagues that it's an and. What are all the things that we can do? We certainly learned around tobacco that it takes multi-dimensional, multi-sectoral kinds of interventions to make a difference. There is no way that improving the cardiovascular health of all people wouldn't require that. But we also have to think about kind of when we might see an effect. If you provide everyone the ability for health insurance, you might be able to measure a change in 1 or 2 years. Think about what Dr. Rodriguez told us. If we could get people's blood pressure under control, we could probably measure a perceptible decrease in mortality due to cardiovascular death and stroke, cardiovascular disease and stroke. However, investing in education, no matter how you do it, we are probably not going to see those opportunities of people who are earning more money, have insurance, are smarter about all the things that go on in their life, invest in their kids' educations. That's going to take many generations, no doubt about it. The last thing I'd say is that our organizations are working sometimes in front and yelling things out. I know 2 of our 3 organizations were at the White House when the opportunity of food as a sector, a possibility to address health and well-being issues in this country was being discussed. But we are also organizations that have those quiet conversations that are not theatrical, that are about laying the groundwork for when a decision needs to be made, a decision can be made. I said last thing, one more thing. If we were to look at some of the policies that you've described have actually taken hold and are moving in a variety of states. And I would say to you that if you were to look at a state-based analysis, you would find that some of the inability to get things done at a federal level is driven by this concentration of influence, power, and voice that does not reflect uniformity about how things are being done in the country, but represent an unwillingness to kind of move with where others have moved. So I'll stop there.
Thank you, and I will add to Dr. Sanchez's comment, and thank you for your questions. You know, your points are well taken, and I would say that something that we were referencing a little earlier. These interactions with policymakers, lawmakers, at whatever level, it's a relationship, and it requires the constant dialogue, interaction with the lawmakers. It also requires recognizing when a new window of opportunity arises and going through that window as quickly as possible to get policy that may have otherwise not been possible, and then thinking about how do you sustain that policy and be able to provide the evidence, the data, whatever technical assistance those lawmakers may need. I'll give as an example this work around the social determinants of health. There is legislation that was introduced. There's a bill called the Improving Social Determinants of Health Act that Representative Nanette Barragan introduced from California that would provide funding for the CDC, for states, localities, tribes, communities to have funding to work on the social determinants of health, because part of the challenge for public health is it's important that much of the funding goes to specifically address specific diseases like cardiovascular disease. That is important. The challenge is that there's not funding to be able to address cross-cutting issues like social determinants of health or provide the infrastructure for workforce. We have an 80,000 person workforce shortage in the public health workforce at state and local health departments. That type of flexible funding is what's needed. And what this bill that Congresswoman Barragan introduced would provide funding to support public health and partners to work on the social determinants of health. She's going to be reintroducing that bill. We had over 500 organizations endorsing and saying, yes, we support this and moving this forward. It wasn't just public health. It was healthcare. It was community organizations. It was the like. So we all have to come together. The lessons that we can learn from civic engagement around mobilization is what we need in our sectors when it comes to policy, and certainly policy at the national level. So I thank you for raising that. And yes, we too need to be held accountable to assuring that we don't relent with regards to trying to advance these types of policies.
I don't want to just add one thing, and we supported the SDOH legislation. The important thing I think to understand is that partnership is so critical. And in our world with the Hispanic healthcare workforce, we have developed a Hispanic Health Professional Leadership Network for years, for 20 years. And it's all the health professional organizations that have the same kind of organizational structure that starts with students. The students that are in nursing school, the nurses that are faculty, the nurses that are in our hospitals. We have dentists, we have pharmacists, we have dietitians, social workers, and we're not just representing doctors. Our organizations have realized that in order to have any kind of resources in our communities to be increased, it takes everybody to learn not only civic engagement, but what we've talked about here is it's not about media and telling people what to do. It's also behind the scenes on influencing the policymakers. And that's what we try to do through our organized efforts. And I would just say that we've all tried to work together, and we need to continue to work together with the African American, Native American, Asian American, and Latinos. One of the things we've done is developed an alliance for multicultural physicians. And that is small, but it's something that we need to start working more across our silos. And we've talked about this in public health forever, but at the leadership level, we really need to figure out a way to have an echo chamber and to build our public health policy influence to a much higher degree. And whatever we can do is important.
Thank you so much, Dr. Rios. That's all the time we have, unfortunately. I will just add the importance of visibility. You have a voice. It is so powerful. And piggybacking off what you said, we are unstoppable when we come together. We saw it on this stage. So thank you so much. A big round of applause for our panelists. Dr. Sanchez, Dr. Gracia, Dr. Rios, thank you so much.
Fireside chat panelists, I'm asking you, please don't leave the stage because we want to just take a brief opportunity to take a picture with you. And I just want to say that want to say thanks to the Hope Challenge team who've made today's event possible. And thank you to the audience, those of you who've come and joined us here in the auditorium, as well as those who've joined us online for this second in our series of events focusing on leveraging health policy to end the preventable health disparity. We invite you to use the QR code displayed on the screen to take a survey asking you about this event, and we encourage you to complete it and so that we may use your feedback to enhance our future events. And then we also ask you to look out for an email announcement regarding our next Hope Challenge Breakfast Forum, which is going to be on maternal and infant mortality, scheduled for March 12th of this year. And again, I want to thank you and wish that you'll have a safe travel to your next destination. And thank you all. And so let's give everyone a round of applause. You all were great. I wish we could continue. But please stay here because this is my reward. I get to have wonderful pictures.